SPC and ISTA, and after that you have to do right ventricular assessment and biomarkers, and if patient show and life-threatening, you have to interfere. According to stratification, you have to decide to treat the patient at home, to treat hospitalized for short period of time, low intermediate risk patient, or to admit to the ICU high or intermediate or high risk patient and go into a refusion therapy. Thank you.
شكرا جزيلا لاستاذنا الدكتور محمد خالد عن محاضره الكلمه. دلوقتي هناخد الاستاذ سامي الحسن يتكلم على كلينيكال بازل كانديديتس دايجنوستس.
السلام عليكم. Let me first start by thanking the Society for the invitation to speak. It's a great honor to be here. And I have a case for you, and I'm hoping that the audience will help me make the diagnosis. Do we agree? Are you with me? All right. Well, the presentation is going to be unorthodox. The way we're going to present the case, I'll give you a few slides, and then I will ask the audience what test you'd like to get next. So be prepared, okay? So I present to you a real case from UCSD, although most of the work was done outside of UCSD. And like they say in the movies, based on a true story, but the producer sometimes plays with the scenario to make it more fun. So for the next 20 minutes, I hope we're going to have to make this into a fun session. Okay, you agree? All right, so let me advance and introduce my patient to you. And if I can get that to work. Okay, here's my friend Jose Rodriguez, and he is from, Mexico, visiting the United States on July 2nd, 2019. Pay attention to the dates, because that's important. And he presents to a clinic in the States with the following complaints. I didn't write any words on the slide. I want you to guess what he's complaining about. Well, obviously he's short of breath, he is sweating, he is tired, fatigued, and he's also coughing something that looks like that. All right? Now, a week earlier, he flew from Mexico to Denver, Colorado, to visit some friends. When he landed, he developed upper respiratory tract infection symptoms, followed by the dyspnea, the exertion, and the cough and the sputum that you've seen. When we obtained further history, he said that for the past 5 months, since February, he's been feeling more lethargic, fatigued, and his exercise tolerance has been dropping. In family history, not very helpful. His father is diabetic, his mother is hypertensive, both grandparents have acute MI. But he's been a bad boy. He smokes like a chimney, 40-pack-year history of smoking. He drinks beer every day, 6 of those beers. And even worse, he smokes methamphetamine. He both injects it intravenously and also smokes it. And you know what methamphetamine can do to the lungs and the heart. In 2009, he was working in demolishing houses in Mexico, and he got exposed to asbestos. He also worked as a machinist in a factory, and he was exposed to hard metal. He was in jail for 5 months in 2017. I'm not going to tell you why he went to jail, but he was. And his travel history is significant for Colorado, where he's visiting friends, and Mexico, where he lives. I finished my history here, and on physical examination, I'm concerned that he's a bit tachycardic, a bit tachypnic, and a bit hypoxemic. And I say, Jose, by the way, I tried to get one of the volunteers to play Jose with me. Nobody wanted to come. The only one who volunteered said he wants $500 to play Jose. So I couldn't get you an actor. So let's pretend that Jose is here, and I'm talking to Jose saying, Jose, I'm concerned about your heart rate being too fast, about your respiratory rate being fast, about your oxygenation. I want you to go to the hospital, Jose. And Jose is from Mexico. He doesn't have insurance, doesn't have money, does not want to go to the hospital. So Jose says no. He is unexamined, tachypneic, diminished breath sounds. He has a little bit of pedal edema, just a trace on the ankles on both sides. Nothing much on exam, not very helpful. And I say, Jose, go to the hospital. And he says in his Spanish language, no bueno, mucho dinero. That's a lot of money, and it's not good. All right, so we do some labs nearby the office, and I see a little bit of leukocytosis, nothing impressive. Differential is unremarkable, as you see. We also get some extra labs, and I see that his kidney is not perfect. His creatinine is 1.4. He has the baseline renal insufficiency. And his liver enzymes just reflect his drinking history, so nothing big there either. And we're still on July 2nd. Now, we also get HIV testing, negative, procalcitonin, negative, so most likely not a bacterial infection. Well, he had a viral infection, we know that. July 2nd, we get a chest x-ray, right-sided pleural effusion, as you can see. I'm done with my presentation. The rest is up to you. Now, I'm going to do something interesting here. And I get to see all the slides, and you don't. So here I'm telling Jose one more time, Jose, you need to go to the hospital, and Jose is saying, absolutely not, he's not listening to me. This is when I turn to you to tell me, what's your differential diagnosis? What does he have? Any volunteers? I guess the list is long. You can guess anything and you'll be right. But I'm going to help you out. You want to say something? Yes? Okay.
He has low lymphedema, and maybe has right heart failure.
Okay. Good reasoning. Okay, good reasoning. Although I would say 10 years exposure to asbestos is too short. You need at least 25 years or 30 years to get asbestosis and mesothelioma and stuff. So I would say a little short. But I'm going to help you here. And for the sake of time also, do you agree as audience? Raise your hands if you agree with me. Could this be a pulmonary infectious etiology? Yes or no? Raise your hands if you say yes. Very nice. And I agree with you. Could this be non-infectious inflammatory disease? Like what? Rheumatologic, vasculitides, GPA, EGPA. There's nothing in the history to support that, right? So I'll give it like a gray color, which is not highly likely. Would you agree this could be cardiac? Agreed. Neoplastic? Smoker? Smoker. 40-pack year history smoking, and now he's coughing up blood. You agree? Show me hands. Neoplastic? Okay, good. You agree? Could this be occupation-related exposure? Worked in a factory, asbestos, like he said. Could it be? At least the baseline, shortness of breath. Could it be drug-induced? Methamphetamine, sure. Diffuse alveolar hemorrhage. Could it be allergic? Hypersensitivity pneumonitis or something? There's nothing in the history to point to that. Could it be vascular? Okay, we're in a vascular session, so everybody's going to say yes. Okay, could it be idiopathic cough or something? Sure, everything is possible. Thank you for helping me with the differential diagnosis. Now, what is the next step? What investigations would you order next? Jose is still sitting in your office. Okay, and I have a pen and a paper. Whatever you ask me to do, I will take notes. So what test? Summer. CT angio. All right. CT angio. I got that down. What else? Echocardiogram. Great. Tapping of the pleural effusion. Great. What else? I wrote all that down. Chest ultrasound. Great. What else? All right. I'm going to work on on your orders, and you requested an echocardiogram, and I'm calling Steve, my good friend from the echocardiogram lab, and I say I have my friend Jose, who's not feeling very well. Can you please get him in for echocardiogram? And he tells me, according to my notes, the earliest he can be in is July 8th, which is a Monday. That's real life case. It's not like you want an echo and it pops up like that. Especially the guy has no insurance. All right, so we are scheduled for an echo on the 8th. That's 6 days away from now. Do you want to do anything else in between? And somebody wanted a CAT scan, right? So I'm calling the hospital. Hello, this is CT. I have a friend of mine. I'm going to send it for a CT. And they give me a date, also the 8th, which is a Monday. So maybe we can do the echo, and then he can swing by the CAT scan and get the CAT scan on the same day. Okay, very good. I'm going to ask the hospital to do an ultrasound as well. And it's all scheduled for the 8th of July. Do you guys want to do anything between now and the 8th of July? Cardiac biomarkers, exactly, troponins. On that slide, this troponin was normal. Yeah, if I want to go back to the slide, I'll show you that it was this slide here that showed, I'm sorry, I took it off. I'm sorry. It was there, but I took it off. D-dimers, very good. Sputum cultures, okay, you're still thinking about an infection. Huh? Blood gases, very good. But it all depends on Jose eventually, right? We want to do a lot of testing. And every time I tell Jose he has to do something, he repeats the phrase, that's why I needed the actor, but he didn't come. He says, no bueno, mucho dinero. So we have to be conscious of the cost. He doesn't have insurance, he doesn't want to spend $1 million on the investigations. Can you think of one test that will give you the answer without spending a lot of money? Bleeding profile? Clotting time, okay, so coagulation workup. Okay, so this is what happens. Let me tell you what happened to Jose. Nobody told me that he's a smoker and I'm worried about COPD. The shortness of breath might be because of airway disease. No? No takers? Nobody wants PFTs? Nobody wants PFTs? Okay, all right. So if nobody wants pulmonary functions, I'm going to show it. But it's there. Nobody wants it. Okay, well, let's just skip. So, echocardiogram, July 8th, I call with the results. Guess what? Jose never showed up. It's a no-show. And we say, well, maybe he's busy getting the CAT scan. Let's not judge him. We called the CAT scan. Jose didn't show up. So I'm sorry, but you're going to have to wait on those results. Well, meanwhile, Jose shows up in the emergency department on July 11th because he was more short of breath. And I get a call from the ER physician saying, your patient is here, he's short of breath, we managed to do an ultrasound of his chest, we found this effusion, and you know, when we find fluid, what do? Put a needle in, and that's what they did. But it is simple, transudative effusion. Nothing spicy there. So, simple fluid. We expected an X-ray, right? Because we thought it's going to be cancer, it's going to be infection, it's going to be DE or something. But it's transudative. A lot of surprise. What happens next? Jose feels better after the fluid is taken out, and he doesn't want to go to the hospital, so he goes back home. And he calls the office on Sunday, July 14th, saying, doctor, I'm coughing up more blood and I'm worried now. I say, Jose, it's Sunday. I don't know what to do for you. You need to go to the hospital. And Jose says, what? No. What does he say? No bueno. Mucho dinero. So I say, well, come into the office next thing in the morning. And he does. And as a knee reflex for pulmonologists, when there's blood out of the airway, what do? We'll look in the airway. So I'm looking to see where the blood is coming from. And the results, airways are patent, there are no masses, BAL is not hemorrhagic. There's a little bit of blood staining the mucosa, no foamy cells, no liquid pneumonia, no eosinophilia. White count is only 57, 300 red cells, normal differential, cytology negative, microbiology workup is negative. At least we know something. We know my suspicion for cancer is less, suspicion for masses is less. So, but we still have not made a diagnosis yet, right? Are you with me? Okay, let's see what we're going to do next. On the 17th of July, Jose feels worse. His friends are now worried. They call the ambulance and they ship him to the hospital. At the hospital, Jose has these vital signs. He's now exhausted, he's becoming hypotensive, more tachycardic, more tachypnic, more hypoxemic. And then they say, Jose, you're coming into the hospital. And no bueno is not going to work. So Jose is admitted to the hospital. Now he's in the hospital under your control. What test did you guys want? Yeah, CT angio and echocardiogram and ABG and nobody mentioned ECG. It's something that we do routinely, right? I think it's useful. Let's look at his ECG because that's the next slide. So here's an ECG, and here's a larger picture of the ECG. Can someone tell me what's going on? It's very good. Huh? Okay. 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 Right atrium. Okay. Right. Okay, very good. These are very good comments. And I'll show you all these things that tell me that the right side of his heart is in trouble. There's RV hypertrophy or dilatation, there's big RA, and there's right axis deviation. So there's something happening on the right side of the heart. Okay, we get an EBG, and he is 747, 30, 64, 21. The guy's hypoxemic. If you calculate his AA gradient, it's about 48. And that's why he's breathing fast. He's tachypnic, making himself alcoholic, breathing down his CO2 to 30. All right. And here is the long-awaited echocardiogram. What do we see? Yeah, the right side is dilated. Right ventricle is big, right atrium is big, and the septum is shifted all the way, compressing that left ventricle. I think that's why he's becoming hypotensive. That there's intraventricular dependence, and then the septum is shifted, squeezing the left ventricle, which is not filling well. So it's not going to be pumping well if it doesn't fill up. So it's very tricky when patients like this present with hypertension. The first thing we do is what? Hypertensive patients, we give what? Fluids. But in this case, it could be detrimental because more fluids means more RV ballooning. And that can shift the septum more and squeeze and choke the left ventricle. So inotropes and diuretics, probably a better way to go. Okay, what is the next test? So you got your echo, you got your ABG, what else would you want? CT angio. Let me see if CT angio is the next study. There you go. Now mystery solved. We have this big major filling defect. Can you see it when I use the mouse? Yes. Okay. So you see the big filling defect? Okay, so what's your diagnosis? Why is Jose short of breath and coughing up blood, and what does he have? Okay, a big pulmonary embolism. At least we say filling defect in the pulmonary artery. Let's say that, okay? Okay, so what's the next study? I guess a couple more views to show you the extent of his pulmonary pathology. Now, the question next is, would you thrombolize? Yes or no? Show me hands. Yes? All in favor? Thrombolytics? Guy's very short of breath, he's getting hypertensive. Yes, he's going to die if you don't do something. And the answer is yes, agreed. And he does get TPA, 100 milligrams, followed by Luvonox, 1 milligram per kg subcutaneously. Today is July 17th, right? You came to the hospital? July 18th. 19th, 20th, and now it's July 21st, and he's feeling much better. He's going home on apixaban. No? Yes? Huh? Okay, what is the reason? Okay, well, we thought he had acute pulmonary embolism. We thrombolized him. We anticoagulated him. He did well. He feels better. He's going home. He's going to continue on anticoagulation. What's wrong with that plan? Why he developed a PE? Well, he was on a plane from Mexico to Colorado. That's about a 4-hour flight. DPT had a little bit of pitting edema. We don't know. Drugs caused hypercoagulability? Okay, all right. So, yes?
Why first when you see the patient first, if you are the treating physician, why didn't ask for simple test, Doppler ultrasound?
Right. I was not the treating physician. That all happened in Colorado. But what I'm saying is, like I told you in the beginning, this scenario is not the true scenario. I added a few things. I took things away just to make it more fun. Okay? Like the pulmonary functions. It was never done, but I put it there. Just in case you asked. I wanted to be ready for every question. Okay? So, let's see what is happening here. Oh. Well, you didn't think I came from San Diego to give you a case of acute pulmonary embolism with TPA, right? That's not it. So we're not done yet. 1 month later, Jose shows up in the office, August 20th, and says, "Doctor, I feel terrible. I can't breathe. His dyspneic, his orthotomy, his chest pains, palpitations on insertion, lower extremity edema, his pro-BNP is rising." And I say, "Jose, you have to go to the hospital." He tries to reject it, but I insist, and Jose is being admitted again to the hospital. All right? Now, at the hospital, we want to think what's happening. We thought we had the right diagnosis. He had a PE. We treated with thrombolytics. He's been compliant with his anticoagulation therapy. So what is happening? Why is he now getting worse? So I say, let's do the following. Which test? Echo again showed the same thing. So RV is only bigger. Okay, you want to see if he's hypercoagulable. Okay, what else? Okay, CT pulmonary angio, see if we still have blockages. Okay, what else? Cardiac cath. Right heart cath. Okay, what else? Okay, so coagulation workup. What else? Okay, very good. Okay, these are all good suggestions. Let's see what the hospital did. They put him in the scanner for a VQ scan. You guys agree? Okay, good. And this was what we found on that VQ scan. I'm going to enlarge it so you can see it better. We have multiple unmatched perfusion defects in both lungs. So we still have areas that are not perfused. So the pathology in the pulmonary circulation remains. Okay, and next we take him to the cath lab. We do the right heart cath. What do we find? And what we found was a surprise, big surprise. Look at that. Look at those numbers. Look at how high the pressures are in the right ventricle, in the pulmonary artery. Let me try to point. I hope it works. Is it working? Can you see? Okay. So look at the pressures in the right ventricle and in the pulmonary artery. Up to 98 systolic. The cardiac index is very poor, 1.3. Look at the pulmonary vascular resistance, 1600. Very, very high. It's about to kill the guy. And his mixed saturation is 50%, indicating that his cardiac output is lousy. So this guy is going to die unless we do something. The next slide is going to be pulmonary angio, invasive pulmonary angiography, and it is showing certain defects that need to be dealt with. At that point, the patient is transferred to UCSD for a diagnosis of CTEPH, which is usually the case. When you treat pulmonary emboli, they don't go away. Then you start thinking about something that does not dissolve with TPA and anticoagulation, something that is so resistant to thrombolytics. And that is what? An organized clot that is called CTEPH, or chronic thromboembolic pulmonary hypertension. Okay? So, at UCSD, these are his numbers. As you saw, his right atrium pressure is high, his pulmonary vascular resistance is so high, his cardiac index is so poor, something needs to be done. So, is this patient a candidate for pulmonary thromboendarterectomy? That's opening the pulmonary artery and taking all the junk out. Is he a candidate or not? Show me hands. Yes or not? Are you in favor of surgery? Of course, it is the only curative intervention for this disease. You can do drugs and medications, everything, but they don't work as well. So here is the UCSD team working on the patient, PTE surgery. Of course, you know this guy, Michael Madani. He's one of the most renowned surgeons. This is how we do the surgery. Hypothermic technique, complete arrest of circulation, open up the pulmonary artery, and take out this. See what it looks like? That's like rubber. I don't even call it a clot anymore. It's an organized clot that looks like rubber, right? This is not going to go away with TPA, apixaban, or all the anticoagulation in the world. You really have to get in and take it out. And that's what the team did. Under the microscope, this is what it looks like. You're going to see red cells, white cells, but in the middle you see all the organization, all the collagen and the fiber. Now, as a good center would do, we have pre and post-op right heart cath to compare the numbers. And look at what happened. Look at the pulmonary vascular resistance dropping from 1,400, almost 1,500 there, to only 134. That's more than 10-fold drop in pulmonary vascular resistance. Look at the improvement in cardiac output and cardiac index. From 2 liters jumping to 5.3 liters. Completely normal. And the patient is a completely normal and a new person. And we do another PQ to make sure all the unmatched effects are gone. And it confirms. One thing I wanted to mention to you. When I'm treating a patient with acute pulmonary embolism or acute pulmonary pathology, because that filling defect doesn't tell me. It could be pulmonary sarcoma, for what I know, right? So how would I know? There's one feature on this CAT scan that is very nice, and I like very much. Look at those arrows, and I'm going to try to get them here. Those arrows here, you know what they're pointing at? You know what that structure is? One here, one there. Those are the bronchial arteries. And they tend to enlarge when you have chronic pulmonary hypertension. As the pressure builds up in the pulmonary circulation, the bronchial arteries become engorged. And that is a sign to tell you, this is not an acute problem. This has been building up over time. And that would have been a clue that you're dealing with a case of CTEPH, not simple acute pulmonary embolism. I like that clue. And obviously you see the big ventricle and everything, and the shift of the septum. And it's worthy to mention that with the enlargement of the bronchial arteries, they can actually compress the left main coronary. And patients may present with like angina and acute MI, when actually the problem is in the bronchial circulation. One word, and you know I'm biased. Is that for me? Okay. This is my last slide, and obviously I'm biased, so UCSD remains #1 in the world, worldwide, dealing with pulmonary CTEPH, because they have done more than 4,000 cases, and they have more success than any other center in the world, and they have the lowest post-operative mortality worldwide. I had prepared something about CTEPH, but I know the next speaker will tell you all about it, and I'm going to stop here, and thank you for helping me.
Thank you very much, Dr. Islam. As usual, you are super. And our next speaker, Professor Yusuf Amin Raslaini, will speak about the same subject. He will speak about chronic thromboembolic pulmonary hypertension, CTEPH, and we'll see his own view about this.
to be here today in the presence of my mentors and my professors and my colleagues. All thanks to the organizing committee, of course, and Professor Ashok Hatton for inviting me here. Homage must be given to my professor and mentor, Professor Medhat Khalid, the one who initiated the pulmonary hypertension unit in Qasr Al Aini, actually. I want to thank him for this. I will be talking about the management of chronic thromboembolic pulmonary hypertension. I will go through the definition and the etiology, pathogenesis, diagnosis, and of course the treatment options available. The definition of CTAF, as any pulmonary hypertension, it's the mean pulmonary artery pressure more than or equal to 25 millimeters